Okay, we are going to talk about Bordetella pertussis, the causative organism of, you guessed it, pertussis. One of the important things to note about pertussis is that this isn't a pneumonia-like disease. This is pertussis. It's different. Um, this one actually causes massive damage just by being an upper respiratory infection. You can have complications, like secondary complications, that include things like pneumonia or encephalitis, but the actual syndrome itself is not considered pneumonia because it's an upper respiratory infection. Okay, so what else about it? Well, it's a small gram-negative coccobacillus. It's a strictly aerobic organism, and it is the causative agent of pertussis, also known as whooping cough. And we'll talk about why it's called whooping cough in a little bit, but really, if you listen to the sound file that I have in the course notes, no explanation is necessary. The disease is toxin mediated, and there are three of them, and you do have to know them as usual. But there are vaccines for this one, which is great because it's actually a really terrible disease. Two acellular vaccines that cover children and adults, which is very helpful. It's a pretty fastidious organism. It requires a specialized medium, Reagan Low or Bordet Gengao. I've always been bad at French names, but sound it out. Um, and basically, these media are enriched with charcoal or blood or albumin or starch. They need these extra additives that help them grow faster. And as long as you have that media, it will grow fairly well. But because it requires the specialized media, culture isn't always the way it is diagnosed. Um, Pertussis is a human disease. It has no other recognized animal or environmental reservoir. So if we could eradicate it from the earth, that would be fantastic. And we get closer every year because there is, like I said, a great vaccine. And that was first released in 1949. And since then, we've seen the incidence of disease go much further down. Okay, so what else about pertussis? Well, when we think about pertussis, we need to think about how it's causing disease. So on the previous slide, I showed you that the organism had all these adhesins. And these adhesins are really important because it allows the bacteria, and I'm showing some here, to adhere to the cilia on the epithelial cells of the respiratory tract. And once they're there, they can proliferate and basically cause localized tissue damage. And this occurs using these fimbriae or protactin or filamentous hemagglutinin. All of these are going to help it attach directly to the actual cilia of our epithelial cells, which is going to make it harder for the cilia to sweep them out as we normally do with organisms. But that's not all. This organism has a couple tricks up its sleeve. So first off, it has three toxins, which I've listed here. There's the adenylate cyclase toxin, the tracheal toxin, and the pertussis toxin. So the adenylate cyclase toxin has, as you might have guessed, direct activity on adenylate cyclase. Um, Adenylate cyclase is an inhibitor of cyclic AMP. So basically what this does is it leads to an increase of cyclic AMP. Now, if you remember when we were talking about some of the bacterial diarrheas, they also had a cyclic AMP pathway, and basically it led to changes in fluid dynamics. And that's the same thing that's going to happen here. So we're going to see increased secretions and increased mucus production. When you've increased secretions and increased mucus production, then it becomes more difficult to breathe. And so that's what's happening with that adenylate cyclase. This is pretty similar to what we see also with the B. anthracis edema toxin. When that occurs in the lungs, it's a similar process. All right, tracheal toxin. This one actually inhibits the cilia from moving. It basically disrupts that normal clearance mechanisms in the respiratory tree, and that's what's actually going to lead to the characteristic whooping cough. And this toxin is actually part of the peptidoglycan wall of the organism. Okay, and then last, and probably most important, is pertussis toxin. This causes the systemic toxicity that's actually associated with the disease. It works by ribosylation of GI, and all that does is have kind of an indirect effect on adenylate cyclase. So GI inhibits adenylate cyclase, which is responsible, obviously, for controlling levels of cyclic AMP. So once again, we're getting an increase in cyclic AMP, and that's going to cause an increase in respiratory secretions and mucus production, just like we saw with the adenylate cyclase toxin. Just now we're doing it in indirect fashion. But it also has another effect. GI is actually really important for chemokine receptor usage. So when you inhibit GI, you actually inhibit chemokine receptors. And when you inhibit chemokine receptors, lymphocytes can't get into the site of infection. So they're going to be recruited there, but now they're going to accumulate in the bloodstream. So this is actually going to lead to a phenomenon that we see clinically known as lymphocytosis, which you'll be able to see in the lab values of patients infected with whooping cough. Okay, so there are 3 clinical stages to pertussis infection. And just like I talked about with Lyme disease, anytime an organism has numerous stages of disease, you better be able to recognize them just by description. So there's an incubation period. That's not technically part of the phases of disease. What we're more worried about are the catarrhal and paroxysmal and convalescent stages. So the catarrhal phase is kind of what we would expect for a standard cold. So about 7 to 10 days after exposure, you're going to have a bad cold for about 1 to 2 weeks. Rhinorrhea, malaise, fever, sneezing, anorexia. You're just going to feel bad. Now, here's the kicker. Your bacterial culture is at its peak here. So this is actually the most infectious stage. And that's dangerous because we don't even know that you have pertussis at this point. So we're not treating you yet. So you can just go around infecting people because we think you just have like rhinovirus. But then things take an interesting turn. So after about 1 to 2 weeks, you enter the paroxysmal phase. During this time, the ciliated epithelial cells basically become damaged. And as they become damaged, mucus clearance is impaired. And that's what's going to cause the classic cough paroxysms. These are coughing fits. They're a series of repetitive severe coughs followed by a loud inspiratory whoop. So what's happening is they're coughing so hard that they're expelling all of the air from their lungs and then trying to pull air back in because it's empty. So you hear that sound. And if you click on the link in the notes, you'll hear it. It's a very heartbreaking sound. So the whooping sound is partially due to these mucus clearance issues that constrict the airway. And the paroxysms are actually kind of stopped each time by vomiting or exhaustion. So basically you cough so much that you throw up. This stage is also going to show that significant leukocytosis as the pertussis toxin goes to work. Patients can have as many as 40 to 50 of these paroxysms per day. So it's a really miserable course of disease and obviously very dangerous to patients who have any sort of pulmonary disease, very debilitating. And then there's the convalescent stage. In some places of the world, this is known as the 100-day cough. Because this one just lasts. Like, you ever had a really bad cough and then like 2 or 3 weeks later, you're still kind of coughing and you're like, oh God, I wish this cough would go away, but you're starting to feel better. This is worse. This one lasts so much longer. So for about 3 to 4 weeks or longer after the 2 to 4 weeks of paroxysm, you're still coughing. It's less, but it's still it's obviously annoying. So this is a really long disease when you think about it. You got at kind of average, you've got 2 weeks of catarrhal, 4 weeks of paroxysmal, so we're at 6, 4 weeks of convalescent. So this could be a 10-week cough, which just sounds miserable. Also during this convalescent stage, sometimes we have secondary complications. So you can get pneumonia due to secondary bacterial infections. We can see seizures or encephalopathy in some patients. Okay. So how do we avoid this? Vaccinate. There's great vaccines for this one. So the vaccines, there's 2 of them. There's Tdap and DTaP. Both vaccines contain inactivated pertussis toxin, filamentous hemagglutinin, and pertactin. The pediatric vaccine is actually administered to children at the ages of 2, 4, 6, and 15 to 18 months. And then children receive a 5th dose between 4 to 6 years of ages. Adults require a booster every 10 years. And one of the things that you might not think of is that one day when you become parents, it might have been a while since you got your most recent pertussis vaccine. And I know what we don't think about is that if you're not giving the baby the vaccine until 2 months, that's 2 months that baby is out in the world unvaccinated. So grandma or grandpa comes to hold them, they haven't been vaccinated in a long time, probably. If your mom or dad, your, you know, clinician will probably recommend that if you've got a new baby in the house, you should re-up your vaccine for this, get a booster. But grandma and grandpa, aunts and uncles, they need to re-up too, because for an adult who's been vaccinated, pertussis isn't a big deal. But for a little baby who hasn't been vaccinated, who's snuggling up to grandma and grandpa, big deal. And that's all I've got on pertussis.